Good morning, everyone. Welcome to today's academic meeting by the Division of Endocrine. It will be our last meeting for this year. So we thought we'd end it with something that may seem basic to the students and regis, but we're always still getting it wrong. We still get consults for inappropriate hypocalcemias or inappropriate workup. I think it's very relevant. We finished the FCP yesterday, and one of the senior nephrologists even mentioned as a side joke that she still looks at her algorithm for hypernatremia as well. So definitely something that's humbling still. And I think our fellow, who is a new fellow in our department, is going to go through it nicely. Thank you.
Okay, good morning. My name is Sayuri Harishun, and the title of my presentation today is The Calcium Uprising. So we were consulted by the obstetric department for a patient with hypercalcemia, a Mrs. DK. She's a 36-year-old female, Grav4 Para1, with a poor obstetric history. She had 2 previous intrauterine fetal deaths and 1 early neonatal death, and was now 16 weeks pregnant. Her background history was being a chronic hypertension, diagnosed after her second pregnancy at the age of 32, and she was on treatment prior to this pregnancy. She also has gestational diabetes and was controlled on diet. She now presents with abdominal pain and reflux symptoms, with no history of bone pain or renal stones, and no history of psychiatric illness or pancreatitis. On examination, she had a blood pressure of 122/70 millimeters mercury and a pulse of 78 beats per minute that were equal bilaterally with no delays. Her fasting plasma glucose was 4. She had no palpable thyroid nodules. Her cardiovascular and respiratory systems were unremarkable. On abdominal examination, she had a gravid uterus with no renal artery bruise, and she had no focal neurology. So to sum up Mrs. DK, she's a 36-year-old female with a background of having a poor obstetric history, chronic hypertensive, of note diagnosed at age 32, and gestational diabetes, at currently 16 weeks gestation. She now came in with hypercalcemia in pregnancy. My first consideration was primary hyperparathyroidism, but we also entertained MEN2A in view of her being a young hypertensive. However, she had no history of a medullary carcinoma of the thyroid and clinically did not have a thyroid nodule at present. So the initial investigations that we saw in the obstetric ward was a renal dysfunction and hypokalemia with a potassium of 2.8, a creatinine of 122, and an eGFR of 47. Her calcium was markedly elevated at 3.99 with a low phosphate of 0.51, and the albumin was normal at 41. So then we repeated the calcium. It was uncuffed and paired with a parathyroid hormone, and it showed an elevated calcium of 3.42 and a parathyroid hormone of 65.1 with a normal vitamin D level of 14. So then we assessed her as having PTH-dependent hypercalcemia. So let me start at the beginning with the physiological functions of calcium. So calcium is involved in the excitation coupling in the heart, synaptic transmission in the nervous system, platelet aggregation, coagulation, and secretion of hormones. In terms of calcium homeostasis, the major regulator of PTH secretion is the concentration of ionized calcium. So an increase in ionized calcium concentration leads to a decrease in parathyroid hormone secretion through the activation of calcium-sensing receptor on the surface of the parathyroid cells. The physiologic relationship between PTH and ionized calcium is that of an inverse sigmoidal curve. And the level of calcium at the midpoint of this curve determines the set point of serum calcium levels. The steepness of the curve reflects that large changes in PTH is induced by relatively small changes in serum calcium. In terms of calcium corrections in concentrations, in body fluids, extracellular calcium levels are tightly regulated within a narrow physiological range. 50% of the total calcium is present in the ionized form, 40% is bound to to albumin, and 10% is complexed with anions such as phosphate and citrates. So the protein-bound calcium and the complex fractions of calcium are metabolically inert and are not regulated by hormones. Only the ionized calcium serves a regulatory role and only this fraction is itself regulated by the calciotropic hormones, parathyroid hormone, and 1.25 dihydroxyvitamin D. So in terms of calcium homeostasis, a decrease in the extracellular calcium triggers an increase in the parathyroid hormone secretion by the calcium sensing receptor on the parathyroid cells. Parathyroid hormone then binds to cell surface receptors in the bone and the kidney, triggering responses that increase blood calcium. So this stimulates bone resorption and delivers calcium into circulation, and it causes an increase in the renal synthesis of calcitrol, which is 1.25 dihydroxyvitamin D, and stimulation of the renal tubular calcium reabsorption. Calcitrol then acts on the intestine to increase absorption of dietary calcium. This results in an increase in blood calcium, and the increase in blood calcium then feeds back onto the parathyroid glands to decrease the secretion of parathyroid hormone. So in terms of the signs and symptoms, it's the famous stones, bones, groans, and psychiatric overtones. So in terms of stones, you get nephrolithiasis and nephrocalcinosis, and nephrogenic diabetes insipidus, which occurs in 20% of patients. Chronic hypercalcemia leads to a defect in the concentrating ability and symptoms of polyuria and polydipsia. And this is due to the downregulation of aquaporin 2 water channels and calcium deposition in the medulla with tubulointerstitial injury and impairment of the interstitial osmotic gradient. In terms of bones, PTH increases bone resorption with subsequent bone buffering and bone loss of calcium and phosphates, and this leads to bone pain, osteopenia, and osteoporosis. In terms of groans, hypercalcemia stimulates gastrin secretion, and this decreases periscalcis and increases the calcium phosphate product with deposition in and obstruction of the pancreatic ducts. So therefore, you get anorexia, nausea and vomiting, bowel hypomotility and constipation, peptic ulcer disease, as well as pancreatitis. In terms of psychiatric overtones, depression, anxiety, difficulty with memory, and concentration are all frequently observed in patients with hypercalcemia. So, the approach to hypercalcemia, when you have a patient with hypercalcemia, is to confirm the hypercalcemia, and we correct the calcium with albumin. Although direct measurements of ionized calcium are possible, they are easily influenced by collection methods and other artifacts. Therefore, it's generally preferable to measure total calcium and albumin and then to correct the serum calcium. After doing that, we then measure the parathyroid hormone and then direct further investigations based on the parathyroid hormone results. So, the approach to hypercalcemia, it's useful to delineate two categories of hypercalcemia. One being PTH-mediated hypercalcemia, which is associated with parathyroid gland dysfunction, and two is PTH-independent hypercalcemia, which occurs despite appropriate suppression of parathyroid hormone. So the predominant cause of PTH-mediated hypercalcemia is primary hyperparathyroidism, in which one or more of the parathyroid glands oversecrete PTH. Then coming on to familial syndromes, the multiple endocrine neoplasia 1 or 2A are also a cause of hypercalcemia. We remember MEN1 as 3 Ps. It stands for pituitary, parathyroid, and pancreatic tumors. Hypercalcemia due to hyperparathyroidism is usually the first feature of this syndrome. Then MEN2A includes medullary carcinoma of the thyroid, pheochromocytoma, and hyperparathyroidism. FFH stands for familial hypocalciuric hypercalcemia. It's an autosomal dominant condition. It is caused by an inactivating mutation of the calcium sensing receptor. The primary defect is abnormal sensing of blood calcium by the parathyroid gland and the renal tubule, causing inappropriate secretion of parathyroid hormone and excessive reabsorption of calcium in the distal tubules. The next cause is tertiary hyperparathyroidism, which usually occurs in patients with end-stage renal disease. It occurs when chronic hypocalcemia, hyperphosphatemia, and impaired synthesis of 1.25 dihydroxyvitamin D leads to parathyroid hyperplasia and eventually to hypercalcemia. Then drugs such as lithium Lithium shifts the set point for inhibition of parathyroid secretion to the right, meaning that this results in hypercalcemia as well as a detectable or elevated level of parathyroid hormone. Lithium can also produce hypocalciuria and thus mimic FHH. Then thiazide diuretics do not cause hypercalcemia on their own, but they can exacerbate hypercalcemia caused by primary hyperparathyroidism. And the mechanism of action includes increased tubular calcium reabsorption. In terms of non-PTH-mediated causes, malignancy is the most common cause here, and there's two mechanisms associated with malignancy. The first being humoral hypercalcemia of malignancy. It's when solid tumors produce PTH-related peptide, which shares homology with PTH in the first 13 amino acids and binds to the PTH receptor, thus mimicking the effects of PTH on bone and kidney. And the second mechanism is local osteolytic hypercalcemia, and this generally occurs when cancer cells are present in multiple sites throughout the skeleton. The next cause of non-PTH-mediated hypercalcemia is granulomatous disease. And in these patients who may have sarcoidosis or TB or fungal infections, they have an excess calcitrol synthesis. So macrophages from the granulomatous tissue convert 25 hydroxyvitamin D to the potent 1.25 dihydroxyvitamin D at an increased rate. Drugs that cause hypercalcemia include excess of vitamin A supplements, as well as calcium supplements. And then endocrinopathies that cause hypercalcemia include hyperthyroidism. And this is due to increased bone turnover, with bone resorption exceeding bone formation. Then pheochromocytoma causes hypercalcemia due to the excess PTH-related peptide. Immobilization causes hypercalcemia due to bone resorption. And milk alkali syndrome includes a triad of hypercalcemia, metabolic alkalosis, and renal failure. And this is a consequence of massive ingestion of calcium and absorbable alkali. So let's go through a diagnostic approach of calcium. If you have a patient with an elevated calcium, to first confirm that it's elevated by doing a corrected calcium or an ionized calcium and doing a paired parathyroid hormone. So if the parathyroid hormone is elevated or normal, the likely considerations is primary hyperparathyroidism or familial hypocalciuric hypercalcemia. Features of FHH include age less than 40, a family history of hypercalcemia, and low urine fractional calcium excretion. If your PTH is suppressed, it is a non-mediated hypercalcemia. The next step would be to measure your 1.25 dihydroxyvitamin D, 25 hydroxyvitamin D, and to look for evidence of malignancy. So if there's evidence of malignancy, it is hypercalcemia of malignancy. If there's an increase in 25 hydroxyvitamin D, it's due to vitamin D intoxication. And if there's an increase in 1.25 dihydroxyvitamin D, it's either a granulomatous disease or a lymphoma. If there's normal vitamin D levels and no evidence of malignancy, to look for other causes such as endocrinopathies or multiple myeloma, which would then need further workup. So now coming to primary hyperparathyroidism. So it's autonomous parathyroid hormone secretion by parathyroid chief cells from one or more of the parathyroid glands that is inappropriate for the level of serum calcium. The incidence is 42 per 100,000, and the prevalence is up to 4 per 100,000 in women over the age of 60. It is 2 to 3 times more common in women than men. So the pathology of primary hyperparathyroidism is a single parathyroid adenoma is the cause of 80 to 85% of cases. Multiglandular disease is responsible for 15 to 20% of cases. Primary hyperplasia is responsible for 10 to 15% of cases. And parathyroid cancer is rare. It's responsible for 1 to 2% of cases, and it normally has a severe hypercalcemia with a palpable neck mass. Just to touch on the ECG changes of hypercalcemia, the most pathognomic is a shortened QT interval. You can also get an Osborne J wave. In extreme hypercalcemia, you can even get ventricular fibrillation on ECG. Clinical features of hyperparathyroidism in terms of the hyperparathyroid bone disease include a salt and pepper sign, and these are multiple, tiny, well-defined lucencies in the calvaria caused by resorption of the trabecular bone. Then, in terms of brown tumors, as indicated by the white arrow, it is localized regions where bone loss is particularly rapid. So hemorrhage, granulation tissue with active vascular and proliferating fibrous tissue replace normal marrow contents, resulting in a brown tumor. It's the hemosiderin that imparts the color brown. Then subperiosteal bone resorption is bone destruction below the periosteum secondary to osteoclastic activity. It results in irregular, lace-like cortical appearance. In terms of bone mineral density, hyperparathyroidism causes a loss of cortical bone. Therefore, if you check the bone mineral density on a DEXA scan, you will see declines at the hip and the forearm. The mass and mechanical strength of the trabecular bone are relatively maintained. In terms of hyperparathyroid kidney disease, you get nephrolithiasis as well as medullary nephrocalcinosis, which is calcification of the medullary pyramids. Patients with hyperparathyroidism and renal stones have a higher 24-hour urine calcium level and higher serum 1.25 dihydroxyvitamin D levels. Hypocyclaturia and hyperoxalaturia are also reported risk factors for renal stone disease. So in terms of evaluating a patient with primary hyperparathyroidism, the first step would be to do a biochemical evaluation, to measure and adjust the serum calcium, to measure the phosphorus, the PTH, the 25-hydroxyvitamin D, and the creatinine, to then evaluate the skeletal evaluation by doing a 3-site DEXA scan, including the distal third of the radius, because we know that it affects the cortical bone more, to also image for vertebral fractures. Then to do a renal evaluation by doing an eGFR or creatinine clearance, a 24-hour urine calcium, as this can aid not only diagnosing FHH, but assessing the risk of stone formation. And for biochemical risk factors for stones, by doing the urine calcium, and then image for stones with a sonar, abdominal X-ray, or CT. So in terms of management, the guidelines for surgery, patients only need one of these guidelines to meet the criteria. So in terms of serum calcium, they need a serum calcium more than 0.25 above the upper limit of normal. In terms of their skeletal system, the bone mineral density has to show osteoporosis or vertebral fractures on imaging by radiograph, CT, MRI, or a vertebral fracture assessment. And in terms of the kidney involvement, they have a reduced eGFR less than 60 or an increased 24-hour urine calcium, as well as the presence of nephrolithiasis or nephrocalcinosis on imaging, and to have an age that's less than 50. So prior to surgery, we do a pre-operative localization for the culprit adenoma. So we normally do a neck sonar as well as a septum. So we start with the ultrasound as the first-line modality, as it is safe, involves no radiation, and adenomas are hypoechoic posterior to the thyroid gland. The sensitivity is 70.4 to 81.4%, with a positive predictive value of 95.3%. In terms of a sestamibi scan, sestamibi is a lipophilic cation and localizes to the hyperfunctioning parathyroid gland by accumulating within the mitochondria-rich oxyphil cells in the parathyroid adenoma. The sensitivity is 64 to 90.6% and has a positive predictive value of 96%. Now, if there's discordant results between the sonar and the sestamibi, then we move to second-line imaging. And this includes the parathyroid 4D CT scan, a PET CT, or an MRI. Then during surgery, we do an intraoperative parathyroid hormone monitoring. And why is this possible? It's possible because the parathyroid hormone has a short half-life, of 3 to 5 minutes, which allows for real-time monitoring of its levels during surgery. Intraoperative parathyroid hormone monitoring helps to ensure that all hypersecreting glands have been excised. Technical factors that affect intraoperative parathyroid hormone readings include hemolysis, renal dysfunction, and sample timing during the surgery. Intraoperative parathyroid hormone-guided parathyroidectomy has a success rate of over 97% for primary hyperparathyroidism. So we use the Rome criteria. You have a persistence of a hypersecreting parathyroid gland if suggested by, firstly, a decrease in intraoperative parathyroid hormone of less than 50 at 20 minutes post-excision compared to the baseline parathyroid hormone, or an intraoperative parathyroid hormone value that remains more than 6.8 at 20 minutes post-excision, or an intraoperative parathyroid hormone value at 20 minutes post-excision, which is 0.8 higher than the 10-minute post-excision, meaning it's on an upward trend. So if the patient does not have any indications for surgery, we then institute medical management. The first and most important medical management is isotonic saline hydration. So we bolus the patient with 1 to 2 liters and then set a rate of 200 to 500 moles per hour and aim for urine output of 100 to 150 moles per hour. The mechanism of action is to restore intravascular volume and to increase urinary calcium excretion. The onset of action is immediate, and the adverse effects include fluid overload. So this modality decreases calcium by 0.25 to 0.375 over the first 24 hours. Then once the patient is volume replete, we then can give the patient loop diuretics. And this increases urine calcium excretion by inhibiting renal calcium absorption in the thick ascending loop of Henle and the proximal and distal renal tubules. The onset of action is 3 to 60 minutes, and the adverse effect is volume depletion. And this lowers calcium by 0.125 to 0.25 after resolution of volume depletion. Then the next modality is bisphosphonates. We have zoledronic acid, which is Zometa, and it's a nitrogen-containing bisphosphonate that inhibits bone resorption within the osteoclast to cause osteoclast apoptosis. It also interferes with osteoclast recruitment and function, and this is only a temporizing measure to surgery. The dose that we use is 4 milligrams IVI over 30 minutes, and it can be repeated in 7 days if the desirable calcium level is not achieved, and every 3 to 4 weeks thereafter. The onset of action is 48 to 72 hours. The adverse effects include renal impairment, especially if the GFR is less than 30, and a dose adjustment, is required if the GFR is less than 16. So bisphosphonate normalizes calcium in 80% of patients within 4 to 6 weeks. Then denosumab, which we do have available at Joburg Gen, is an antibody to rank ligand. Upon binding to rank ligand, it blocks the interaction between rank ligand and rank and prevents osteoclast formation and thus bone resorption. The onset of action is 3 to 10 days, and the adverse effects include atypical femoral fractures. Osteonecrosis of the jaw is infrequent, but the most important one is rebound osteoclastogenesis may occur with discontinuation of the drug. It's not a long-term measure. Patients with a GFR of less than 30 have a high risk of hypocalcemia, and dose adjustment is required. The time to complete response is 23 days. Then on to calcium mimetics, which is cinacalcet. Cinacalcet is a calcium sensing receptor agonist, which reduces parathyroid hormone secretion and decreases renal calcium reabsorption. So the onset of action is 2 to 3 days, and the adverse effects include nausea, vomiting, headache, and fractures. And it reduces calcium by at least 0.25 in approximately 60% of patients. So patients who don't undergo surgery require monitoring to see if they do develop indications for surgery. Therefore, it's vital to check their serum calcium and 25 hydroxy vitamin D levels annually, to also check their parathyroid hormone levels, to then check their 3-site DEXA scan every 1 to 2 years, unless their bone mineral density is normal, to also do vertebral x-rays to look for fractures, to check their creatinine clearance annually, and to do abdominal imaging to look for renal stones, as well as a 24-hour urine calcium. So just back to our patients, this is the trend of our patient's calcium on medical management 4 days before she went to theatre. You can see some improvement in her calcium on her saline infusion. In terms of primary hyperparathyroidism and pregnancy, during pregnancy, the plasma volume expansion and reduced albumin concentration contributes to a decrease in total calcium concentration. The required calcium for the growing fetal skeleton are mainly derived from an increased intestinal absorption of calcium in the mother. And this process is stimulated by estrogen and 1.25 dihydroxyvitamin D, which is increased by 2 to 3-fold in the pregnant woman. PTH-related peptides is significantly increased in pregnancy and is mainly derived from the placenta and the breasts, where it is stimulated by prolactin. PTH-related peptide exerts PTH-like effects and is an important regulator of calcium homeostasis during pregnancy. After delivery and during lactation, calcitrol normalizes, while PTH-related peptide is further increased. So the physiological changes of pregnancy, such as the low albumin, hemodilution, increased glomerular filtration rate, and an active calcium transport across the placenta, all contribute to lower calcium level in pregnancy and can mask the presence of primary hyperparathyroidism. Therefore, ionized calcium should be measured when primary hyperparathyroidism is suspected in pregnancy. Hereditary syndromes such as the MEN1, MEN2A, and FHH that I mentioned earlier all need to be excluded, given the young age of pregnant women. So imaging in pregnancy, like we do in the non-pregnant patient, is to start with the neck sonar. It's the first-line image modality, and it has no radiation. However, if the neck sonar is inconclusive, we can move to an MRI. And the reason for using an MRI in pregnancy is because it lacks ionizing radiation. But if an ultrasound is inconclusive, or if an MRI is unavailable, which is a very likely scenario, functional imaging such as PET-CT or cystometry should be considered. So unfortunately, PET-CT does have the addition of the CT part, which adds a low dose of X-ray exposure to the fetus, whereas cystometry is the better modality because there's lower radiation exposure to the fetus than PET-CT, and the radiation dose during the second pregnancy is at a much lower level than levels known to cause malformations or hypothyroidism. So management in pregnancy. Mild cases should be managed by maintaining good hydration and monitoring calcium levels. Bisphosphonates and denosumab should not be used in pregnancy, and there's very limited data on cinacalcet. Pregnancy should be considered in the second trimester, and this is ideal due to the reduced risks of fetal organogenesis issues in the first trimester and preterm labor in the third trimester. Pre-operative imaging should be limited to ultrasound. If surgery is deferred, the neonate should be closely monitored for hypocalcemia. And if surgery is deferred, a parathyroidectomy should be done after delivery and before a subsequent pregnancy. So back to our patient, Mrs. DK. She had a neck sonar, and in the conclusion, a solid lesion was seen. However, the sonographer noted that it was extremely difficult to assess whether it was a thyroid lesion or a parathyroid lesion. So a neck sonar was inconclusive. For that reason, we then proceeded to assess the MEB scan. And the early and late phases of the cystometry demonstrated a site of increased uptake inferior to the right thyroid lobe. She then underwent a right inferior parathyroidectomy, and the histology confirmed that it was a parathyroid adenoma. In her surgery, she had intraoperative parathyroid hormone monitoring. If you can see, her pre-incision PTH was 81.5. Already by the 10-minute mark, it came down to 3.7, which is showing, using Rome criteria, that they have got the culprit adenoma. And at 20 minutes, it was 3.2, also confirming it. So this is the trend of our patient's calcium. Sorry, it's supposed to say post-operatively. It's back to normal from her pre-operative calcium, which was between 3 and 4. So the take-home message is, number one, the first step in workup of hypercalcemia is to confirm the results by correcting for albumin and checking ionized calcium. Number two would be to direct further investigations based on parathyroid hormone results. Number three is that the preoperative localization includes a neck ultrasound and sestamibi. Only if this is discordant, then the patient is for second-line imaging. Number four, in terms of management, to look for indications of surgery or conservatively manage but continue to monitor your patients. Number five is that the intraoperative parathyroid hormone guided parathyroidectomy has a success rate of over 97%. And number six is, in pregnancy, limit the pre-op imaging to a sonar, do not use denosumab and bisphosphonates, and consider surgery in the second trimester. Thank you.